think what's encouraging is that it looks like in addition to improving hemoglobin, it's also improving the neutrophil count and platelet counts in these patients. And I think that it's attractive because some of these patients have already had the available therapies and had progressed through them. So they're looking for their next option. What I presented was the negative results of the Verona trial, which compared aza-venetoclax to aza placebo, which was disappointing. I think what I tried to highlight is that there were limitations in that study related to enrolling patients with less blast count, older age, and some with better risk disease. So the benefit of aza-venetoclax was probably less in those patients. The overall response rate appeared to be not as beneficial to the combination. But I think what we've learned as a field is that picking the right patient for this combination, you can derive a benefit, particularly in patients under the age of 75 with high-risk cytogenetics and a higher blast count greater than 5%. This is a very difficult to treat disease. I think what we've seen in 4 negative trials in this space is that these patients can do well in smaller trials, but when it comes to larger trials, there's limited benefit. So this is a novel mechanism of action using the CLEVER pathway, which hasn't been targeted before, and looks like doesn't have a lot of side effects. So the results of that trial were looking at older ALL patients who generally do poorly with chemotherapy-based backbone treatments. So giving them inotuzumab followed by Blincyto treatments, we were able to see effective results in terms of disease control and less deaths due to toxicity of the regimen. So overall, patients did better.